Good evening, everybody. Good evening, everyone, and welcome to this evening's Gastro Echo Fellow Training Program, which is hosted by the Gastro Foundation in association with Project Echo from the University of New Mexico. The Gastro Echo Fellows program is run every second Monday at 6, and this evening is going to be with myself, Bilal Bobat from Donald Gordon Liver Unit, as well as Dr. Pascal Kuka, who's going to be running us through the complications of cirrhosis. Please remember that the chat is open for questions that you can put through as we go. Try and put them in the chat so that some of the quick, easy ones between Pascal and myself we may be able to answer as we go. And some of the other ones we'll use for discussion towards the end. I'd like to, not delay any further then and introduce Dr. Pascal Kuka, about to be second year fellow with us on the Johannesburg circuit. Pascal, over to you.
Right. Thank you, Dr. Bobat. So we'll get started. Today we're going to discuss complications of a condition that we see very commonly. It's not only a condition, but a multitude of conditions in one. I'm sure you encounter it almost every day in our training, and we'll encounter it more and more later on in your future. So, as you know, it's a long topic to discuss. We'll try and look at the different complications. We'll look at the pathophysiology of them, look at the clinical scenarios and the management strategies. So because it's also like a series of talks, I think we'll be having breaks for discussions every 20 or so minutes so that we're able to keep up with the whole presentation. Okay. So these are some of the sources that we got, not only the major guidelines, the ASLD, ESL, but also a very important paper written by some of our faculty, including the moderator today. So it's a paper that kind of looks at the ideal way of management of complications of cirrhosis versus what we have on our side as well. So this will be the main source of information. So we'll start with definitions. So as we know, cirrhosis is where you have fibrotic changes and nodular regeneration of the liver due to multiple insults. We won't look at all of the insults, but we are trying to look at the end stage of all these processes. So the other definitions will be compensated advanced chronic liver disease, which is defined by initially use of liver elastography of more than 15 kilopascals, which defines that liver stiffness. And compensated advanced chronic liver disease can be divided into two based on whether you have clinical significant portal hypertension or not. The definition of clinical significant portal hypertension also is based on wedge pressures of more than 10 or a liver stiffness of more than 25 kilopascals. And in cases where the transient elastography is less than 15 kilopascals and a platelet of more than 50, it kind of almost rules out the possibility of clinical significant portal hypertension. So what about decompensated cirrhosis? This is where we have significant events like ascites, hepatic encephalopathy, and GI bleed. And although our talk today is majorly on cirrhosis, but you also need to understand the definition of acute liver failure, where you have initially the insult, which ends up to impaired function presenting as encephalopathy, and is further subdivided depending on the period of presentation. So we'll get started, still continuing on the use of liver stiffness. This is an invasive way to put you at risk of developing other complications. So you can think about the stiffness as divided into 5, so from 5 to 10, all the way to 25. So patients who have a liver stiffness of more than 15, they are assumed to have compensated advanced chronic liver disease. Whereas most of the complications might, if you have more than 25, that's when you assume clinical significant portal hypertension. The next description is about the risk of developing complications. So these are also both non-invasive as well as invasive methods of trying to define how risky someone is at. So using your platelets, liver stiffness as well, and hepatic venous pressure gradient. So once you start getting to venous pressure gradients of more than 10, that's when you have a high risk of developing decompensated cirrhosis. So this was a study that looked at patients who presented with acute decompensated cirrhosis. It was a prospective study that followed them up for up to 360 days. And from this study, we're able to define patients with acute decompensation into three different groups. So one, there are those patients who have a pre-ACLF, pre-acute and chronic liver failure, and the patients who have unstable decompensated cirrhosis, and patients who have stable decompensated cirrhosis. So as you can see from, as you can see from the chart, patients who are defined to have pre-ACLF will have very many incidents of decompensation as well as death within the first 90 days, as opposed to patients who are unstable and stable decompensated. So even if you compare the patients who are unstable versus stable, the incidences of death within the first 90 days and progressively are higher in the patients with unstable compensated cirrhosis. So the main differences in these three groups, other than the presence of portal hypertension, is also the level of inflammation. Patients who eventually develop acute and chronic liver failure will have significantly high levels of inflammation, as evidenced by the CRP levels and the white count levels. So this study just guides us in terms of when patient presents with the acute decompensation to try and tailor them in terms of their risk of developing acute and chronic liver failure, which as can be shown, associated with the significant morbidity and mortality. So we'll look at some of the complications which could be related to portal hypertension and non-portal hypertension. So we'll get started with ascites. So ascites can be classified based on the amount that is there into mild, moderate, and severe. But the other significant classification is also regarding whether it's uncomplicated, in which there is no evidence of infection, and also there is no association with renal dysfunction. Refractory ascites is where, despite adequate therapy, you're unable to prevent recurrence within 4 weeks. So that can be divided into diuretic resistance, into where, despite adequate dosages of your diuretics, in this case, spironolactone of more than up to 400, and furosemide of up to 160. But it's widely known that in clinical scenarios, we rarely achieve these high levels. And the next classification is where you have complications for the treatment. So things like electrolyte abnormalities and development of renal failure. So we looked at, there's a study that looked at patients who present with ascites as the index decompensation episode. So if you look at the patient who presents with the grade 3 ascites, only less than a third of them will further not have any other decompensating feature in about 1 or 2 years' time, as opposed to patients who have grade 2 ascites. Up to half of them might not have any decompensating event. In this case, if they are well treated. So anytime a patient presents with some certain level of ascites, you also need to look at them in wholesome and see the risk of developing other complications in the future. So this is a figure that we've looked at a number of times, the pathophysiology of ascites, but also it also explains a lot of the events that we'll be looking at today. So as you know, eventually starts with the production of vasodilators, which then causes splanchnic vasodilatation, leading to pooling within the splanchnic area, leading to decreased effective arterial blood volume, which activates the vasoconstrictor systems, leading to sodium and water retention. So this also is some of the targets that you use for treatment for ascites. So how do you evaluate a patient presenting with ascites? So the first evaluation is your clinical scenario. If it's the index presentation, you look out for any features of chronic liver disease, and from your history, also trying to tease out the likely etiology. Shifting dullness in moderate to or severe ascites has been shown to have a high sensitivity for detecting ascites. In cases where you're unable to to detect ascites by clinical examination. Imaging can be used, but can also show any other complications associated with the ascites. So diagnostic paracentesis is key in managing of ascites. So for patients who have SBP, that will be defined by neutrophil count of more than 250 cells, and also a greater specificity if it's more than 500. But a caution is when you have very high levels of polymolecular cells, you also need to think about any secondary infection which might be warranted, for example, any visceral perforation or any other injuries. The role of culture, either culture positive or culture negative ascites is managed more or less in the same way. But they also, because of the low yield of cultures, there is a role for bacterial DNA detection, but of course that is not very much used in the clinical scenario. Protein and albumin levels are key in calculating your SAG, as we shall see in the next slide. Cytology and these other tests will be applicable in the appropriate scenarios. So let's look at SAG, because SAG, it helps us a lot in terms of how we manage patients. So SAG of more than 1.1 or 11, depending on the criteria that you use, is suggestive of portal hypertension. And after that, you can also use acidic protein to decide whether it's cirrhotic or sinusoidal, in which case you look at any venous outflow obstruction or any cardiogenic cause of the ascites. For peritoneal disease, that's where cytology or evaluation for TB might be warranted. So how do you treat ascites? So the first key role is dietary salt restriction. So although we are told about figures like restricting to 80 to 100 sodium equivalents in a day, but that's a bit hard sometimes to implement in clinical scenario. So one of the easiest ways is just to ask the patient not to take any added salt to their food, or not to cook any to eat any pre-cooked or any packaged meals. Diuretics are a cornerstone in management, but we need to remember that it only provides a symptomatic benefit and does not modify the natural history of ascites. We start with spironolactone at a dose of 100 milligrams, and we titrate it every 3 to 4 days to achieve our targets that we shall see later on. Amiloride is not recommended, and in cases where spironolactone is not tolerated or due to side effects like gynecomastia, then eplerenone is an option. So if you talk about furosemide, there are two approaches that we can go. We can either use the sequential or combination therapy with a balance in terms of either trying to achieve a control of ascites as rapidly as possible versus developing the complications of therapy in combination therapy. So in moderate ascites, it's recommended to start with spironolactone as a monotherapy, but in persistent or severe ascites, then a combination might be warranted, especially if the patient is admitted, in which case you can titrate to your targets as well as try and observe for any complications. So the target for patients who don't have any peripheral edema is less than 0.5 per kg versus 1 kg per day, 1 kg per day of weight loss for patients who have peripheral edema. What about the role of therapeutic paracentesis? So it also helps in rapid mobilization. We define large volume as where you evacuate more than 5 liters at a setting. And in this case, albumin is recommended for large volume paracentesis based on this study, which is more than 30 years ago. But it compared the use of albumin versus colloids in incidence of post-paracentesis circulatory dysfunction. So the figure in crosses is the use of colloids, which was significantly had a higher significant incidence of renal dysfunction in patients who had evacuation of more than 5 liters, and even more significant in more than 9 liters. So other than large volume paracentesis, we also use albumin in SBP and renal impairment, and also in patients who present with acute and chronic failure. The role of TIPS in ascites, it achieves good control and also improves the patient's quality of life. But these cautions that we look out for, not only in ascites, but also applicable to other scenarios. So the incidence of hepatic encephalopathy, thrombosis, and stenosis, and also the limited availability in different settings. We always cautious in patients who are elderly and patients who have a MELD of more than 18 because of the risk of worsening the other complications, and also patients who have hepatic encephalopathy. Contraindications will be heart failure and pulmonary hypertension because of the increase in the systemic outflow and increase in right-sided pressures with TIPS. What about this condition that is closely associated with the ascites? So we need to diagnose SBP as soon as possible because with every delay, there's a risk of mortality, just the same way that we get increase in mortality with the sepsis. Diagnostic paracentesis we've already talked about, but another thing to mention is the risk of infection in cases where you have total protein of less than 15. Empiric antibiotics, in our setting, we commonly use ceftriaxone, but generally we also need to look at the local resistant pattern, and local resistance patterns might guide you into what antibiotics to use. So something that we rarely do commonly in a clinical setting is a repeat in the diagnostic tab after about 48 hours to see whether you have achievement of reduction of your neutrophil count by more than 25%, which is suggestive that the drugs are indeed effective. So what about patients in terms of prophylaxis in SBP? So we've already talked about high-risk patients being those with the low cytic protein. But as we know, as a matter of principle, patients presenting with acute GI bleed, we normally cover them with the antibiotics to prevent development of SBP. And also patients who have prior SBP have a high risk of developing the same. So for primary prophylaxis, different guidelines recommend norfloxacin. But from the paper from Sub-Saharan Africa reports norfloxacin being less available than ciprofloxacin, and the general concern of long-term antibiotics. So rifaximin doesn't have a major role in prophylaxis of SBP. So another condition closely associated with the ascites is hepatic hydrothorax, in which case you get micro leaks in the diaphragmatic defects leading to accumulation of fluid, most of the time up to 70% on the right, but it can also be purely on the left, also bilateral. So development of hepatic hydrothorax has a poor prognosis with a mean survival of less than a year. The treatment initially is the same approach to ascites, but then in refractory hepatic hydrothorax, then these other options, including thoracentesis and TIPS, and also eventually liver transplant should be considered. So next, we'll move on to the next condition, and then we'll have a bit of a break to discuss these two conditions. So GI bleed in cirrhosis, 70% of bleed in portal hypertension is variceal, and the risk of variceal bleed increases with the advancement of the chronic liver disease. The other risks depend on the size of the varices and the red well signs. So for patients who present with any sort of decompensation, or a patient presenting with the bleeds in advanced cirrhosis, there is a higher chance that their varices have progressed from previously small to large. So it's just something to keep in mind. So this is from the Bavano criteria about which patients to screen for varices. So it's recommended that patients who have a liver stiffness of less than 20 or platelets of more than 50 do not require an upper endoscopy for screening. But patients who have liver stiffness of more than 20, platelets of more than 150, then it's recommended that to screen for upper endoscopy. And depending on the findings of low-risk varices or high-risk varices, then primary prophylaxis, and which includes banding ligation and non-selective beta blockers. In this case, carvedilol being a first choice because of its effects on the splanchnic system as well. And then after that, you repeat the endoscopy in up to 1 to 4 week intervals until eradication. And then after that, you continue following up for every 3 to 6 months or every 6 to 12 months. So what about presentation with an acute GI bleed? So after doing the necessary resuscitation, you initiate them on terlipressin or somatostatin. We've already discussed about the role of antibiotic prophylaxis, and it's advised that we do an early diagnostic endoscopy within 12 hours. And if you confirm the varices, we do ligate them and then maintain them on vasoactive therapy for about 3 to 4 days. So in up to 85%, we're able to achieve control. But in patients who are high risk, then we consider tips. We'll look at these patients in the next slide. In other cases, you might not be able to achieve control of bleeding, so other options will be esophageal stenting or balloon tamponade. But then there's also a role for rescue tips. As I said, we'll discuss more about tips now. So we've already talked about cavadial and endoscopic band ligation, but for tips, for patients who come with bleed, one, there are two different approaches. Number one, there's a preemptive approach in patients who have advanced liver disease with the CHAL-P of more than B7 or CHAL-P of C, with an active bleed at endoscopy, or with the hepatic venous wedge pressure of more than 20. But the other approach is if you're unable to control bleeding from the other interventions, then a salvage tip might be warranted. However, tips is ineffective in cases where you've not planned for transplant in this group of patients. One, patients who have advanced CHAL-P of more than 14, MELD of more than 30, and a lactate of more than 12. In cases of gastric varices, then coiling or injection of glue might be warranted. And although therapy guided by hepatic venous pressure gradient might be ideal, but is also invasive and is very limited in terms of availability. So I think we can discuss about the next two cases and then we'll go on. Dr. Bobat.
Fantastic. Thanks, Pascal. So I'm not sure if anyone I'd want to put up their hands. Any comments? I think if you just have a look in the chat, I have just referenced Pascal. Just go back to your the British guideline that you used for your ascites recommendations. Okay, so it's published in Gut in 2021. Have a look for that. It's from BASIL, British Association for the Study of Liver. And why I like it is that remember that they're using similar units to us. They have similar ways of thinking and so on. And yeah, I think they've got a fantastic approach. Okay. Dominique's quite chatty here. Let's see what, in terms of ratio of eplerenone to furosemide and management of massive ascites and ratio, then yeah. So really, I can't really comment on these. I've used eplerenone once where the patient was somewhat intolerant, but had fairly well controlled ascites at the time. I think what I did was I actually chatted to one of my cardiology colleagues and I said, look, in your experience, what's the rough ratio that we use? And I cannot recall it. It's been some time back. Then in terms of hepatic hydrothorax, yes, it is actually possible to have fairly minimal ascites and have it all being sucked up into the chest. So you'll have complete whiteout. Remember that it is most common for hepatic hydrothorax to occur on the right, not so much on the left. If you're having a pleural effusion that's occurring on the left, you need to look a bit harder. A lot of the criteria that we use to try and differentiate between exudates and transudates are a little bit off, considering the protein and albumin state in cirrhosis. So yeah, and then let's see what else. Then how would we manage ectopic varices in the context of portal hypertension, like varices on a stoma? Great question. We have in the past placed. This is generally via what we've done in the past is manage it via interventional radiology, and we go in and we embolize those varices. Your first step would probably be looking at putting a TIPS in, and then going in and embolizing those. I'll refer you to the I think it was last year or the year before AASLD AASLD guideline on TIPS and various other interventional radiology interventions such as Berto, Carto, Parto, all these various occlusive type therapies using a combination of things such as coils and balloons or other sclerosants. And yeah, that works pretty well. Obviously, etiological management is your crucial. Manage your etiology, and then you go on to things such as carvedilol and so on. Anything else? Anyone putting their hands up or anything like that? It's fantastic. There's 35 people on. Thanks for joining us on this decent Joburg. It's a bit of a chilly, wet day. Otherwise, Pascal, anything you want to add before we continue?
No, not really. I think we can
Right,
continue
push on
to the
then.
next topic. All right. So the next topic will be renal impairment in cirrhosis. So we are well aware about the different triggers, infections induced by diuretics, as well as other interventions like paracentesis. But we also need to keep an eye on some of the other drugs that you use other than the diuretics. So in terms of etiology of renal dysfunction, the common pathway that has been well described will be the splanchnic vasodilation and if reduced effective arterial volume. But recently, there's also been a role for cirrhotic cardiomyopathy in terms of reduce in the stress response to the heart, as well as the role of bacterial translocation in terms of your pattern and the damage associated molecular patterns, which induce inflammatory response, leading to either direct kidney injury or contributing to the splanchnic arterial vasodilatation. So this is a figure in terms of how to approach patients presenting with renal dysfunction. So one, in terms of definition of an AKI is where you have a presentation with more than increase of serum creatinine by more than 26 or increase by 50% from the baseline. In that case, you need to determine whether it's pre-renal or renal. So we have different ways to use that. So one, look at the urine sediment. So it is suggestive of renal disease if you have proteinuria or macrohematuria, or if a renal ultrasound indeed confirms that there is structural disease. And in that case, you treat according to the etiology. So in terms of pre-renal, you also determine the stage based on the levels of creatinine. And initially, you try and assess the likely precipitant. So you talked about infections, whether someone has had any GI or otherwise volume losses, and also nephrotoxic drugs. So after withdrawing the same and trying to achieve volume expansion with albumin and close monitoring of the same for about 48 hours as we try and correct the initial insult. So if you don't have any response in terms of reduction of the creatinine to less than 26 of the baseline within 48 hours, then that fulfills the criteria of hepatorenal syndrome, which, as you know, previously was described as type 1 and type 2, but the new definitions will be are hepatorenal syndrome, AKI, or hepatorenal syndrome non-AKI, in case they don't meet the criteria that has been defined above. Hepatorenal syndrome non-AKI has further been subdivided into acute kidney disease and chronic kidney disease, depending on the period of time, the 3 months being the cutoff of the same. So in that case is when vasoconstrictors and albumin will be warranted to see whether there's a response or not. There is later on down the stream, in case you don't have any improvement, there is a role for simultaneous kidney and liver transplant, for which there are different guidelines based on how long someone has been dialysis, between 8 to 12 weeks, depending on whether we're looking at the European or the American guidelines. But also patients who have CKD stage 3B for more than 90 days will also be considered for hepatorenal transplant. So let's switch back to hepatorenal syndrome or AKI. So we've already talked about the criteria, and it's been well established that clinicians rarely use the urinary output to define AKI in general. other than using the serum creatinine. So as you said, it's where you don't have any good response within 48 hours, and you've ruled out concomitant shock, nephrotic syndrome, or any renal parenchyma disease. The vasoconstrictors, the one that has been well studied is talipressin, but in situations where talipressin is not available, then norepinephrine and albumin with a target map of more than 10% from the baseline is also an option. Midodrine and ectrodide are considered to be less effective. And the indications for dialysis are the same indications that we use generally, acidemia, fluid overload, electrolyte abnormalities. The role for TIPS is not well used in hepatorenal AKI, but is considered if the MELD is less than 18 and total bilirubin is less than 80. Then, like any other advanced complication, a liver transplant is also an option for hepatorenal AKI. So let's talk a bit more about talipressin. We all know it's a vasoconstrictor that acts on either the splanchnic and the renal tubules. And in terms of its management, we assess its efficacy by looking at the decrease in creatinine in 48 hours. So if there's no decrease, then we increase the dosage. And in cases after increasing the dosage, we also continue it for a longer period of time for up to 14 days. The side effects of talipressin are also very important to keep in mind. So abdominal cramps, diarrhea, and any sort of ischemia, either cardiac or intestinal. Most commonly, you also get skin discoloration, especially in the extremities. And respiratory failure is also a limiting side effect for talipressin. What about hyponatremia, also closely associated with the renal dysfunction? Can be either hypovolemic or hypo or hypervolemic, depending on whether there's fluid loss or fluid overload. And as well know, sodium has been included in the assessment of MELD because it's been shown to have a better prognostic score. And the initial evaluation is just like the general evaluation for hyponatremia, where you check your urine osmolarity, and depending on whether it's, depending on the osmolarity and volume status, the serum osmolarity, that also guides to in terms of treatment. But the general principles of treatment will be fluid restriction to less than 1 liter per day, which can be higher in case of severe hyponatremia of less than 125. In cases of hypovolemic hyponatremia, then volume expansion is warranted, and patients presenting with the complications like CNS complications like seizures, then hypertonic saline will be warranted. Tolvaptan and other vaptans are not recommended in management of hyponatremia. So next, we'll move on to the other complication of cirrhosis, which is hepatic encephalopathy. So this is brain dysfunction due to not only liver insufficiency, but also photosystemic shunting. It has a huge impact in terms of morbidity and mortality. And something that we also forget is just the amount of care burden fatigue that hepatic encephalopathy confers to the people who are taking care of the patient, as well as recurrent hospitalization. So there are different ways of classifying hepatic encephalopathy, which are known as the four axes. So one, depending on the type, is it in acute liver failure? Is it in photosystemic shunting or cirrhosis? We know about the Westhaven criteria for grading of hepatic encephalopathy, but keep in mind that you can also get covert encephalopathy. And based on the time course, whether it's episodic, recurrent, or persistent, in terms of whether there is barely any resolution or barely any return to baseline. And then depending on whether you can identify any precipitants, you can say there's precipitated or spontaneous. So the main pathophysiological mechanism in hepatic encephalopathy is hypoammonemia, but there's also the role of these other other stressors like inflammation, oxidative stress, bile acids, and manganese. All these lead to, once they cross the blood-brain barrier, will lead to astrocyte swelling and dysfunction, leading to brain edema and the risk of the presentation that hepatic encephalopathy comes with. But you also need to keep in mind of all the other precipitants that can precipitate hepatic encephalopathy. So how do we diagnose? So for covert HE, you might require psychometric or neurophysiological tests, but some manifestations of grade 1 could be things like some might be tending towards psychiatric like anxiety or dysphoria, but also issues with their sleep and awareness. And then anytime someone presents with the overt, then you also need to exclude other causes like any sort of trauma, or the etiology, things like alcohol withdrawal and all that. So what about the role of ammonia measurement in hepatic encephalopathy? So one, it has a high negative predictive value, in that when it's negative and someone has altered mental status, then you need to look carefully for other causes of the same. But you need to keep in mind how careful handling of the sample needs to be done, so that you're able to achieve correct and consistent results. The level in cirrhosis, it's unclear whether there is any correlation with severity or prognosis of hepatic encephalopathy. This, unlike in acute liver failure, where it's known that levels of more than 200 confer a high risk of brain edema and also a risk of cerebral herniation. But all in all, whether we use high levels of ammonia in cirrhosis to target a treatment is controversial, depending on the guidelines or depending on the practice at different areas. So the treatment, patients who have, risk of, airway loss. So patients who are grade 3 to 4, GCS of 8, then you need to transfer them to critical care to consider intubation. And you need to rule out other precipitants. The role of lactulose is well known. We'll look at the mechanism of action of lactulose in the next slide, but it's used as primary prevention in advanced liver disease. But in patients who are unable to tolerate lactulose oral, there's also a role in rectal lactulose, but polyethylene glycol can be used for rapid mobilization, in terms of trying to reduce your ammonia levels. Rifaximin is used as add-on therapy to lactulose, and this amino acid, L-ornithine, L-aspartate, can also be used in cases of refractory to the above first line. So we talked about lactulose, but what are the mechanisms of action? So one, it's converted to lactic acid and acetic acid, this case reducing gut lumen, and by then also leads to overgrowth of your non-aminogenic lactobacilli, as well as preventing reduction to ammonia thereby, and therefore you have reduced level of absorbed ammonia. Also, the catalytic action of increasing your bowel movements also leads to reduced ammonia absorption. So what about patients who have persistent or refractory hepatic encephalopathy? So one, in presence of shunts and patients who have a MELD of more than 11, then you can consider embolization of the shunts. Patients who are acutely presenting with hepatic encephalopathy, ending up in critical care, you can consider albumin dialysis. And also the role of nutrition, not only in and or outpatient, but also need to prevent sarcopenia to promote the role of muscle in the glutamine synthesis. So the ultimate treatment is liver transplantation, but there is still lots of cases. I mean, it's a varied figure depending on studies that have been done, but there is persistent complications in some transplant recipients, which could be due to the long-standing anemia or other insults versus due to the primary etiology. There are trials going on in terms of the role of fecal microbiota transplant to try and stimulate the hepatic urea synthesis in terms of modifying the microbiome in the gut. So I don't know, Dr. Bobat, if we'll discuss the next case before the last two cases before moving on to the last batch of syndromes.
Hi, yeah, Pascal, well done. Couple questions that have come through. So just scrolling up here. Yeah, Jess messaged me. Just she's fresh from having written the exam. Yes, it's the AASLD Practice Guideline 24. When I was referring to tips and your various other interventional therapies. So go have a look at that regarding your peristomal varices and so on. Another question, can we combine non-selective beta blockers with variceal band ligation for primary prophylaxis in cirrhosis, right? Or is it just in the context of a patient that has already bled? Where a patient hasn't bled yet, you're talking about primary prophylaxis, and in this case, your your main thrust needs to be address the etiology of the cirrhosis. That is going to be emphasis, emphasis, emphasis. You'll see, like, especially with alcohol-associated liver disease, with Hep B-associated liver disease, those patients improve quite rapidly and drop their pressures quite nicely. And then, would you then look at doing both or not? There were a number of trials looking at the use of beta blockers, and beta blockers have been shown not just to prevent variceal bleeding, but rather prevent all forms of decompensation. This is from the Predesi trial, Predesci, I think it is. Predesi trial from probably about 5 years ago now, 5, 6 years ago. And it really was what, really said carvedilol is our beta blocker of choice, number one. And number two, we need to be using it as soon as we suspect clinically advanced, even compensated liver disease. Specifically, it was shown to reduce the time onset of first ascites. There are a couple of trials that are one which was released at the end of last year called the Caliber trial. That one looked at this combination with primary prophylaxis of beta blocker and variceal band ligation, especially when they're high-risk varices. And frankly, I think this kind of just matches what our clinical practice is currently, where if you're going to see high-risk varices, it's very unlikely that you're going to ignore them and just say, I'm happy with the beta blocker when you've got a scope down there already. So there's a little bit more evidence for the endoscopist who's willing to band to now stand on. The other trial that's coming out is the BOP trial that has completed recruiting, and we'd still anticipate those results. And both of those are looking at primary prophylaxis in terms of combination, right? Then looking through here, should rifaximin still be in this algorithm? Pascal, can you go back? Let's just have a look to see what Prof. Fredericks was talking about, which just want to have another look at it. Is that the algorithm? Was it one up?
Yeah, so it's not really an algorithm because that's the only place where I mentioned
Okay.
as add-on.
So rifaximin it's important to remember that rifaximin is add-on therapy, and it's not necessarily for it's not first line. It's a recognized second line treatment to either prevent after a significant first episode of encephalopathy. Generally, if you have a second bout, despite being on lactulose, that's when you're going to be prescribed rifaximin. It's not just in South Africa that this drug is heinously expensive. It's all over the world that it's pretty dear. Hopefully this price comes down, because it is a wonderfully effective agent. Is giving lactulose, is there any role in adding gentamicin? I don't think there's a role in adding gentamicin. There were previously, before the era of rifaximin, they talked about adding in that, such as neomycin, metronidazole, oral ampicillin. These were all used for gut decontamination. And then Prof. VG has raised his hand. Go ahead, VG.
Prof, I don't know, I think with the rifaximin issue, it's that recently I think Ernst may want to also speak to this, that recently it's been shown that it really isn't reducing more like mortality. May improve the encephalopathy a bit, but considering as you did like mention now its expense, and if it's not significantly reducing more like mortality, is it worthwhile for it to still be on an algorithm? I know it's a bit controversial, but I don't know if Ernst
Well,
was alluding to that.
I
Ernst?
think it certainly prevents morbidity, and it keeps patients out of hospital. That has been shown in terms of health economics in the States, looking at
Yeah,
some of
sure.
the data, preventing episodes of grade 2 and 3 encephalopathy with patients being admitted. So absolutely for that, yes. In terms of their overall outcome, you're now
Yeah,
dealing with someone that is failing first-line therapy, and this is rescue therapy, so it is by no means reversing the liver failure in any way. In addition, it has not been proven to assist in terms of spontaneous bacterial peritonitis prophylaxis, nor has it been shown as adequate therapy for instance, once you have post-variceal bleeding or anything like that. So
sure.
no, your end outcome in terms of mortality, you need a liver transplant or directed therapy towards your liver in order to make that true difference. And rifaximin is really just plastering over issues.
Sure.
Right. And then, yeah, resistant bacteria. And this is something that's brand new. And what it's been shown, I don't know where it was published, but the use of rifaximin has encouraged specific bacteria, and I can't remember which ones, where they then get cross resistance to daptomycin. I think was the specific bacteria shown to be and antibiotic shown to be effective, but it's not necessarily it doesn't necessarily encourage broad-based resistance. Okay, Pascal, you want to go ahead?
Yes,
Oh,
sure.
sorry, sorry,
So,
sorry, sorry. Just back to that slide of yours there. One thing that just airway protection. Watch out if you've got someone already a grade 3 encephalopathy, you're going to be intubating this patient. Only then can you consider things such as PEG or your bowel prep type solutions. Be careful about this in terms of volume and hyponatremia. Make sure that the patient isn't already hyponatremic before putting down a large volume of fluid into them. What I'd often do is I do give patients a fleet enema, especially with your brittle encephalopathic patients, where the family can just administer a fleet while waiting for a hospital bed. And that often helps. But there is a study looking at PEG and ascorbic acid, what we commonly know as Moviprep, which settles down encephalopathic patients a lot quicker than your standard approach of a lactulose bolus. A bolus would mean something like 30 mils per ostat. Again, remember, if your patient is confused and agitated, and you may need to protect the airway first before talking about putting 30 mils of lactulose down their throat. Yeah, and then what else was there? Treatment as well. Look at your electrolytes: low potassium, hyponatremia, hypophosphatemia. These are things that these patients suffer from with their various diuretic therapies. They can get dehydrated and their balance knock off, and therefore they become encephalopathic. Have a hard search for any further infections that may be precipitating the encephalopathic crisis. Okay, Pascal, over to you.
all right. So as I said, we look at the last batch of mostly cardiopulmonary complications. So we look at the first three. starting with the portopulmonary hypertension, which is a pulmonary hypertension, but ruling out of other causes in patients who have portal hypertension as well. The criteria is where you have elevated mean pulmonary arterial pressures and also an elevated pulmonary vascular resistance, but a normal wedge pressure of less than 15. So based on the mean pulmonary pressures, they can be divided into mild, moderate, and severe, severe being more than 45. So there's a comparison between uh, pulmonary hypertension versus other forms of pulmonary hypertension. Has been shown that portal pulmonary hypertension has a lower survival within 5 years as compared to either idiopathic or other pulmonary causes, other pulmonary hypertension. So how do the patients present? So one, they can be asymptomatic, but can also present with the exertional dyspnea and so with features of right-sided heart failure. The main risk factors are one, female, and number two, patients who have autoimmune liver disease, but also patients who have spontaneous polysystemic shunts. So initially, we screen by doing an echo for patients who are symptomatic, but sometimes it can be picked up in patients who are being evaluated for liver transplant or patients who are being evaluated for TIPS. And in cases of, finding of right ventricular pressures of more than 50, then that will warrant right heart catheterization for confirmation of the same. So the pathogenesis and treatment is almost similar to general pulmonary hypertension, and that's why there is a role of endothelin receptor antagonists like bosentan and the role of phosphodiesterase inhibitors like sildenafil in terms of management of portal pulmonary hypertension. The outcomes, one, it is a relative contraindication. That's portal pulmonary hypertension, especially for severe. But in patients who have moderate pulmonary hypertension and undergo liver transplant, there's a high risk of prolonged hospital stay and ventilator dependence. But patients who are indeed candidates for liver transplant, they need to be aggressively optimized prior to having a liver transplant done. So the next syndrome is hepatopulmonary syndrome, which is due to intrapulmonary vasodilatation causing a VQ mismatch. So it's diagnosed as having hypoxia, or doing a blood gas of PO2 of less than 70, or an arterial gradient of more than 15. But also, you need to discern any defects on a contrast echo or a lung perfusion scan. So it can appear in these different settings and cirrhosis or patients who have prehepatic portal hypertension, as well as in acute liver failure. So also there is a role of mediators of angiogenesis that will cause the vasodilatation. In this case, leading to, as I said, a VQ mismatch due to shunting. The presentations will be dyspnea and platypnea and orthodoxia are classically known to present with hepatopulmonary syndrome. In this case, where there is desaturation after moving from a supine to an upright position, and also in long-standing hepatopulmonary syndrome, they present with finger clubbing. It has a poor prognosis, up to 23% 5-year survival. And because of that, patients who have HPS are indeed put high on the list in terms of getting MELD points of 22 and additional points every 3 months. And it has good outcomes with up to 85% of correction of hypoxemia post-transplant. Next, we look at briefly at cirrhotic cardiomyopathy, which is cardiac dysfunction in patients with cirrhosis, but in absence of any other non-cardiac disease. So it's mostly diagnosed either in echo or an MRI, and it presents with both systolic dysfunction. In this case, you have a blunted response to stressors, or diastolic dysfunction. And it can present as these different causes. Number one, patients can be asymptomatic, and in this case, can only manifest when there is a change in the hemodynamics, either post TIPS or post liver transplant. But it can also complicate your AKI. So patients who are being managed for AKI or HRS and not improving, then that could be a manifestation of cirrhotic cardiomyopathy. And there isn't any standard treatment for that other than symptomatic treatment and addressing the possible etiology of liver transplantation. So next, we'll look at a musculoskeletal complication, which will be a final complication that we'll look at. So it's sarcopenia and frailty, which, respectively, are impaired muscle mass versus an impaired muscle function. So this sarcopenia is diagnosed based on imaging, doing a scale MRI or CT muscle index, and frailty. There are different, scores to assess your frailty. So liver frailty index, performance status, and the simple 6-minute walk test. The pathophysiology of it is known, is assumed to be the inflammatory response and hyponatremia affecting the muscle fibers. And the treatment for it, the first one will be optimization of the etiology of the liver disease, role of nutrition. We talked about protein diet before, and the patient being put on an exercise program. And in cases of males and low testosterone levels, there's a role of supplementation of testosterone, but with contraindications like age, any previous malignancies which might be responsive to testosterone. So, in summary, cirrhosis, as we've seen, can present with multitude of complications. We've discussed most of the major ones, but there's still a lot more that we haven't discussed. And the management requires multidisciplinary approach. We've seen that there's different complications, for example, cardiac, pulmonary, which might involve other specialties and also other ancillary specialties like nutritionist. And you need to recognize early the complications and treat based on target. And although we have guidelines from all over the world and standard therapy, but you also need to adapt the same to our local resources and expertise. And as we mentioned in most of the complications, the definitive therapy for many of the advanced complications is liver transplantation. Thank you very much.
Thanks, Pascal. Anything, what's it, 2 minutes to 7. Any other comments or questions? I think, your hepatopulmonary syndrome and portopulmonary, it's important to be aware of. Your clues for hepatopulmonary syndrome is especially in a female with significant spider nevi and clubbing. Look a bit harder for have a high index of suspicion for HPS. They're not necessarily going to be giving you a history of orthodeoxia or platypnea. And yeah, it's interesting. We've actually had a bit of a run after a long time without seeing any. It's been a bit of a run. We've, I think, had 3 patients present with HPS towards the end of last year and the beginning of this year.
Hi,
Uh,
Bilal.
yeah,
Sorry to quickly interrupt. Just a quick thing from my side about HPS. Screening patients with cirrhosis with a SATS like probe, any help that as a good screening
that's
uh,
the
like a
you
test?
that's one of your first tests that you do on them. I think what is important is that in the patient that I recently picked up, her SATs were above 92 at rest, but as soon as I exercised her a little bit, she dropped. And so it certainly still is a useful screen.
Yeah, no, I have to say strangely enough, it was during like in COVID that we ended up actually
Yeah,
finding a few because as they entered the hospital, they all got their to their out to our out like patient clinic. They had a routine stats like like
yeah,
checked. And if it hadn't been for that, we probably wouldn't have realized that they had HPS. So
yeah.
maybe it's something for all of us to consider that when we see all these patients with cirrhosis as an like a patient, whenever they visit, to ask that they check the like blood pressure, pulse, and stats as well.
100%, 100%. And then weight. If you go
Mm.
back to what Pascal was talking about in terms of societies, weight is, a daily weight for your patient at home in terms of assessing what their weight is doing, and then in the clinic each time is super important for assessing your ascites compliance and allowing the patient to figure out where they are, where they're sitting. Remember, one of the things with your average patient with ascites that's controlled, and not necessarily an inpatient, going out living life. If they go off to a family lunch where they don't realize that they aren't actually put in quite a bit of salt in a dish that they're not necessarily tasting the direct salt, they may see on Monday, Tuesday, Wednesday, their weight incrementally increase. And that's fluid, right? And just with them having that little bit of knowledge that cut back your salt intake as your first step, maybe go up by 50 milligrams on the spironolactone, 20 milligrams on the Lasix, may settle them down without that spiral of them needing things such as taps and so on. Anything else? If not, 7:02. Pascal, thanks and congratulations on an excellent presentation. Great job. Next week, it's going to be my colleague, Dr. Dinan Parbu, who is going to be with Ibrahim Mohammed. And the topic is hepatocellular carcinoma. The latest EASL guideline on this has just been released. So for the fellows, read up on that and come with some good directed questions for the panelists. Good night, everybody. Thanks for joining.